Saurav,
Sir, 1 minute, sir, 1 minute. Just 1 second. Sir, we can start, sir.
madam, please, we can start.
Oh, hi, good morning, everyone. I'm really sorry about the technical issue here. And first of all, I thank Dr. Srinivas and Dr. Ghanshyam for having me on this platform here today. Next few minutes, I'm going to talk on what are antibiograms and how are they used on bedside in ICUs and how to select antibiotics based on MICs. It sounds a little bit dry and boring topic, but it's important to have a knowledge on microbiology and antimicrobials and the work which is being done in the micro lab to help us treating patients with various infections. It's a boon to have good microbiologist and lab in the hospital, which definitely improves your outcomes. So
Next slide. Its slides are not moving, madam.
can you hear me now? Hello?
We can hear you now. We can hear
Sometimes
you
we
now.
see, well, thank you. Sometimes we see the failure of treatment, which could be with one of these reasons, could be because of drug selection pressure, when the antibiotic ill-chosen or given in too small doses or duration, leading to survival of microorganisms and producing resistant mechanisms. And the other one is the Eagle effect. Here, when the dose of antibiotics is much higher than optimal doses, it paradoxically reduces the antibacterial effect. And the other one is the heteroresistance. It's a phenotype in which the bacterial isolate contains subpopulations with reduced antibiotic susceptibility compared to the main population. These kind of things like we see on the disc where we see the zone of inhibition, and within that zone of inhibition, we see the growth of the subpopulation. So I'm going to start with a case scenario here. It's a 78-year-old female patient, known case of uncontrolled diabetes, admitted with cellulitis left leg with septic shock. She has undergone debridement and the pus sent for culture sensitivity. The empirical antibiotics started were piperacillin, tazobactam, and clindamycin. So the AST report shows moderate growth of E. coli, which came on day 3 of starting empirical antibiotics. So this is the report which I'm going to do at the end of the talk. So which is showing some resistance and some sensitivity and some I which is intermediate. So which I am going to talk at the end of the talk. So what are antibiograms? Coming to antibiograms, which are defined as annual reports of cumulative pathogen incidence and antibiotic susceptibility data in an institute. So antibiograms are utilized to surveillance the bacterial resistant rates and potential patterns to highlight the trends over the time within an institute. And they help us in guiding the empirical antibiotic therapies. So, CLSI guidelines for antibiogram are like we have to have minimum number of isolates, same isolates within the year or 30. So if we don't have 30 isolates of same pathogen, we can use at level 1, 5 organisms of either gram-negative or gram-positive. One of them like 5 combined organisms, or at level 2, do it as a direct gram stain, 30 numbers, or at level 3 where the organism is identified. Empirical therapy depends on the susceptibility % cutoff of an agent for an infective syndrome caused by suspected organism or the group. So as per CLSI guidelines, in a patient who is in ICU, sick patient, and history of multi-drug resistant organism or having high mortality risk, you need to have at least more than 90% susceptibility to recommend that to give as empirical antibiotic. But for Indian scenario, we take it as more than 80% susceptibility. Like for a stable patient, OPD or IP stable patients without very high mortality risk, we can give like more than 80% susceptibilities. Okay, and in our scenario, we accept it if it is more than 60% susceptibility. So I'm going to show some examples of antibiogram, like our hospital counts of isolates and antimicrobial susceptibilities of our antibiogram. So this is showing ICU blood and body fluids, the GNB counts, which is showing E. coli more than 30, and then Klebsiella, Salmonella, and other things. So we have enough numbers here. It's a 38. So this is a number we can see what are the susceptible antimicrobials. So here we can see fosfomycin 100% susceptible, amikacin 87, gentamicin 79, and meropenem 76. So if we take it as empirical antibiotic, we hardly have much choice. So only fosfomycin, amikacin going above 80% susceptibility, gentamicin, meropenem above 75%. And similarly, ICU ET GNBs, we can see Klebsiella only 22. So it's not coming up to 30. So we add other things, other gram negatives, like next one is Acinetobacter pseudomonas. Combined, we have definitely more than 30. So this is the susceptibility, and this is showing like hardly anything is susceptible above 80%. So when the susceptibility is not reaching above 80%, for a sick patient, we can't give monotherapy. This is the urine, and you can see a lot of E. coli, more than 100. So, and these are the susceptibilities. So here we have all these meropenem, gentamicin, amikacin, and fosfomycin. They are above 80%. So now coming to selection of antibiotics based on MICs and probably MPC, which I'll talk in a minute. So what are MICs? MIC is minimal inhibitory concentration, is the lowest concentration of antibacterial agent in milligrams per liter or mics per ml, which under strictly controlled in vitro conditions completely prevents visible growth of test strain of the organism. And what is MBC? MBC is minimal bactericidal concentration, is the lowest concentration of the antimicrobial agent that kills the test organism. So bactericidal drugs have MBC 2 to 4 times the MIC. So now this new thing, what's called MPC, this is a mutant prevention concentration. It's defined as the lowest drug concentration required to block the growth of the least susceptible cell present in the high density bacterial population. So we take the density of the inoculum as 10 to the power 10 here. So it applies to microorganisms considered susceptible to the drug by MIC testing. So here in MPC, like in MIC, we have the coverage up to 99%, but in a MPC, you cover up to total 100%. So 0% is susceptible, for 0% is left to become resistant. So total prevention. And there's something called MSW. What is MSW? It's a mutant selection window. It's defined as the danger zone for the therapeutic drug concentration. Minimizing the length of time the drug concentration remains in MSW window will reduce the likelihood of resistant selection during therapy. This MSW lies, it's between MIC and MPC values. I'll show you the graph here. And here in this graph, you can see antibiotic concentration on the x-axis and percentage of colonies recovered on the y-axis. Where you can see MIC, you have only 1% is recovered. So the colonies. But in MPC, the red line it's showing you are covered, it's totally inhibited. So 0% is recovered. So the window between MIC and MPC is the MSW. So antibiotic concentration range for which the evolution of resistance can occur for the subpopulation in this window. So the limitations of MPC are like it's low repeatability and it has very wide variability and it's not easily predictable because we don't know which subpopulation is going to have resistance and which is not. And so initially we start with MIC doses and start using, but when the patient doesn't show improvement on the further cultures, we see resistance again. So that could be because of subpopulation resistance. And to get MPCs, we need prolonged incubation periods like up to 72 hours. and it's not being done in many labs. I think it's only being done only in research centers and labs right now. So the techniques which are used for antibiotic susceptibility testing are the diffusion, dilution, or the diffusion and dilution techniques. The diffusion technique is a qualitative method using the Kirby-Burr method or Stokes method. And the dilution methods are quantitative methods using the tube dilution or agar dilution. And diffusion and dilution uses the E-test strips, which are gradiated concentration of antibiotic strips, which are used to test this. And we have automated systems for AST, which are Vitek, which is widely used in India. And the others are Phoenix system and Microscan walkaway system. There are advanced and rapid diagnostic tools like PCR or MALDI-TOF or PNF fish test, but all these, this is beyond the scope of this talk. So when we do when we get the sample from patient, the first step is getting to see whether it's a gram positive or gram negative. So in this, there are a serial of like a series of things which are being done, which are fixing the sample on a slide first, then using the crystal violet, and then iodine treatment, decolorization. At the end, we see the counter stain with safranin, which shows the gram positive as violet and gram negative as pink. You can see here. And the agar plates, which are used to grow the inoculum, which are different types, blood agar or chocolate agar, McConkey agar, nutrient agar, SDA agar. These are used depending on the type of sample or the gram positive or negative which you get on the sample. So blood agar, usually hemolytics, we use blood agar for, and the respiratory ones, chocolate agar being used, and McConkey agar is used for GNBs, and nutrient agar for pigmented strains, and STA for fungal. And it takes about 18 to 24 hours for inoculum to form. So these are the plates which are showing here are chocolate, blood, nutrient agar, and McConkey agar. So this is the disc diffusion method. In this, in the agar plate, antibiotics are added to the plate, which has been streaked with the inoculum. And after a period of incubation for about 18 to 24 hours, a zone of inhibition is seen here, and which determines the susceptibility of the antimicrobial agent. The wider the diameter of the zone of inhibition, the more susceptible. So what are the limitations for using this disc diffusion method? Disc diffusion, it delays, but there's a delay between application of disc and incubation, and the composition of medium affects the interpretation. The inoculum density may affect the zone size. So heavy inoculum may result in smaller zones and vice versa. Fastidious organism may not grow on this medium, so may need to require supplementation of blood. Proper storage of disc is important, which may affect the potency of the drug. Under some circumstances, in vitro results may not show in vivo. So this is the This is the dilution method where you have micro titer well plates. Here, like a quantified amount of microorganism is added to each well with varying concentration of antibiotics. Here you can see the black circles indicate no bacterial growth. So the minimum inhibitory concentration is determined by identifying the lowest concentration that inhibits bacterial growth. So here you can see the MIC for antibiotic A is 32 mics per ml, and for antibiotic C is 0.5 mics per ml. So these are the, I'm showing some of the, how it's being done in the lab. So initially from agar plates, they're taking the sample, inoculum sample with the loop and put it in diluent tubes and mix it well and put them in densitometer to get it to the required density, and then add it to the plates, microtiter well plates. Then put them in the Vitek machine, leave it for 18 to 24 hours when we get the report on the screen. So this is the E-strip using the diffusion and dilution technique. Here the microorganism is streaked onto the agar plate, and E-test strip, which has the gradiated antibiotic concentration placed on the top of it, and it is incubated for 24 hours, and you'll see the zone of inhibition in the form of ellipse, and where it intersects, that is the MIC, and the antibiotic in this example MIC is about 2 mics per ml. So these are the synergy tests, like synergy tests using E-strips. You can see the first one not showing synergy at all. The middle one is showing synergy, and the last one is showing partial. So this is a broth dilution method. In this, quantified concentration of microorganism is on agar plate. The minimum inhibitory concentration determined by identifying lowest concentration of antibiotic inhibiting the growth. So here you can see the MIC is 32 mics per ml. So these are the new ones. It's for colistin, broth microdilution for colistin. These are the cards available. You can see where the color changes to purple. That's the MIC of colistin. So interpretation of antimicrobial susceptibility test. You see on the reports, you can see MIC, what you get, and whether it is sensitive, intermediate, or resistant interpretation. So what is intermediate resistance? It represents a buffer zone that prevents strains with borderline susceptibility from being incorrectly categorized as resistant. So, the intermediate resistant ones, you can have a successful treatment if you increase the dose or the dosing regimen is changed, or if the infection at the site where antimicrobial concentrates. Similarly, the success is less likely if you use the dose which you use for susceptible category is administered, or infection is at the site where antimicrobial doesn't concentrate. So what are MIC breakpoints? So antibiotic breakpoint is the dilution where the bacteria begin to show resistance. The breakpoint and the range of dilutions differ by drug and bacterial species. So the breakpoints are determined by using pharmacological and epidemiological approaches called ECOF, and they are set by CLSI That's a US based, and the UCAST European one. And they've been reviewed periodically. So I have some examples of ASTs set by CLSI. So the breakpoint set by CLSI, they have different panels for different pathogens and antimicrobial agents. So you can see here for enterobacterials, all these, and the green ones which are showing are the MIC range which we get in our labs, and the blue one susceptible or intermediate or resistant which are given by CLSI. Similarly, for Pseudomonas and for Acinetobacter, for all these, for gram-negative ones, you can see the panel number is different, like panel number is N406. And for gram-positive, the panel is different one. So you have different spectrum of antibiotics for susceptibility testing for gram-positives. So these are the examples for gram-positive ones. So coming to breakpoint MIC quotient or therapeutic index. So what is it? It's a ratio of clinical breakpoint MIC to the MIC achieved for the isolate for that antibiotic in our lab. So the greater the therapeutic index, lesser is the MBC, and therefore the better effect. And it should be at least one or more than one to consider that particular antibiotic for that isolate infection. So it's important to know a little bit about intrinsic resistance. Intrinsic resistance is defined as inherent or innate antimicrobial resistance of all or almost all representatives of the species. And it's important to avoid inappropriate or ineffective therapies. Enterobacteriaceae are intrinsically resistant to these antibiotics like clindamycin, daptomycin, glycopeptides, macrolides, rifampin. And gram-positive bacteria are intrinsically resistant to aztreonam, polymyxin, and colistin. And non-fermentative gram-negative bacteria are intrinsically resistant to penicillins and some classes of cephalosporins, clindamycin, glycopeptides, and macrolides. So what are the limitations of MIC? To get the MIC, we need at least 2-3 days time. Meanwhile, the empirical antibiotic is being given, which the patient may not respond or may become more sick. So an MIC not given as an exact value because the panels contain several fixed concentration of antibiotic. And it doesn't take into account of pharmacokinetics, immune system, nutrition, and drug interactions. So tests are performed specific standardized inoculum in vitro, but if the bacteria is greater at the site of infection, therapy may not be effective. The virulence of strain is not reflected in determining the MIC. So how do we choose optimal antibiotic? For empirical therapy, we use antibiograms. If you have one in your institute, go with that and look at the susceptibility if it's more than 80% or for sick patients or more than 60% for a stable patient, and use that as empirical therapy. And also take into consideration of site of infection and patient condition. And target therapy, we take antimicrobial susceptibility testing reports, and we go with that. And factors to consider while choosing antibiotic are not only MIC. I don't think right now we are using MPC, which needs more studies to be done to take that into consideration. The therapeutic index, PKPD of the patient, site of infection, and penetration of antimicrobial agent to the site, and the availability and the cost of the antimicrobial agent. So here we see PKPDs where you see concentration dependent antibiotics like aminoglycosides, quinolones. The Cmax is important. So Cmax by MIC. Cmax should be like at least 3 to 4 times the MIC. And for the time dependent antibiotics, it's the time which the drug should be in the system at the level of MIC. So that's why for beta-lactams, carbapenems, and all these, we give as infusion over a period of 3 to 4 hours. So it's good to know about selective reporting of antimicrobial susceptibility because it's important for antimicrobial stewardship program. So what is selective testing and what is selective reporting? Selective testing is like AST may not be performed for a particular bug drug combination for some reasons where bacteria suspected of being contaminant or usual flora, we don't do ASTs. And if susceptibility or resistance can be predicted based on the organism identification alone, which is like when you think intrinsic resistance. And drug may not be on the chosen panel in the automated instruments if the drug-bug combination has no interpretative breakpoints, like CLSI may not give breakpoint for some drugs like for example, colistin. So selective reporting may be done for particular bug-drug combination is inappropriate for a given site of infection. So dapto-AST not reported on respiratory source of infections. And also reporting is not done if a drug is not in the facility formulary or if a drug may be inappropriate for particular patient population, like for example, fluoroquinolones and tetracyclines not reported for children. And the drug giving suboptimal outcomes in treatments of severe infections or resistant phenotypes. We may see susceptible for carbapenem, but it may be positive for carbapenemase test. So AST results reporting may be modified when a secondary phenotype is performed showing inducible resistance or interpretation of cephalosporins from susceptible to resistance based on positive ESBL test, or when a secondary molecular test like a genetic test performed like NAT showing positive for MECA gene for Staph aureus isolate report and report it as resistant to methicillin oxacillin, though it was susceptible based on MICs. So what is cascade reporting? So AST results for a particular bug drug combination are obtained, but results are not reported for broader spectrum of agents unless the bug is resistant to narrow spectrum agents. So the cascade reporting it's a part of selective reporting. So cascade reporting, selective reporting, all these play important role in antimicrobial stewardship programs. Like carbapenem AST results not reported for E. coli if the isolate is susceptible to ceftriaxone. So So coming to our patient report, so you can see a lot of resistance in cephalosporins, but you can see carbapenem sensitive and then TG-cycline sensitive, colistin intermediate. So how did we decide on using the antibiotic here? We see therapeutic index. So you have the breakpoints from CLSI or UCAST, and look at the ratio of breakpoint and MIC, and you got a therapeutic index of 8 for meropenem, imipenem, and 4 ertapenem. And you see TG-cycline, you got the therapeutic index of 8. So here we have the patient with cellulitis leg with debridement and pus formation and septic shock. So like imipenem is not a good choice. So from meropenem and TG-cycline were chosen for this patient. So conclusion is use antibiotics for infection, not for contamination. Antibiograms are useful for rational use of empirical antibiotics. Consider site of infection and PKPD along with MIC. Do not compare MIC between drugs. Bacteria may show heterogeneous mechanisms of resistance, persistence, which may lead to treatment failure despite the right choice of therapy. And we need more research and studies for MPCs. And antimicrobial stewardship programs are cornerstone for process improvement, which involves staff education, infection prevention, source control, appropriate antibiotic with proper dose, and culture reports, depending on culture reports, and surveillance of AMR and hospital-acquired infections. Thank you. Thank you.
Thank you, madam. Excellent and as usual, crisp and informative talk. I think quite
I can't hear you. Hello?
aspects have been, I hope everyone was listening to it. Only thing I would like to say, am I audible?
Yeah, now audible.
Yeah, so I think it was an excellent and crisp talk as usual. And I think all of us have actually understood a few concepts which were nebulous, which were probably gray zones after this talk. Only point I would like to add is that it's just not interpreting the MICs, which is probably at the end of the spectrum of antimicrobial therapy. What sample we send, what is the time lapse between the sampling and analysis, and what is the time, the turnaround time for the sample to be analyzed and reported back to the clinician. They all form several steps in the choice of the process of selection of an antibiotic, and that is what we mean by diagnostic stewardship. So if you have a patient who has a surgical infection, for example, just sending a wound swab from superficial skin is not going to be the right way of sampling it, because we end up getting a polymicrobial culture and then we start using a combination of antibiotics resulting in the resistance pattern. So deep-seated swabs should always be considered for such patients. So such stewardship issues, diagnostic stewardship issues should be implemented if we want to conserve the few antibiotics which we have at our disposal. Similarly, it cannot be pan cultures for everything. We should make a diligent effort to understand which exactly is the source and what exactly is the organism we are trying to implement. And as has already been said, in vitro sensitivity may not always mean in vivo efficacy of an antimicrobial. Similarly, something which is in vitro resistant may sometimes have a synergy when used with another antibiotic in vivo. So these concepts and these principles should be remembered when we prescribe antimicrobials in the ICU. And this talk is something which is a guide for all those for taking those steps. Thank you very much, madam, for your time. We'll meet again next week. Next week with approach to undifferentiated shock. And for those of you who are logged in, our journal club sessions also will be restarting next Thursday. That is not tomorrow, but the Thursday after, with the study on early decompression for intracerebral hemorrhage. So please do join us for the journal club as well and for the next session of HICS. Thank you all and have a good day. Bye bye.
Thank you.